job is fairly structured in having morning and afternoon sessions that are timetabled. And every week we are slightly different, but if you're taking a typical day, we would have, say, clinic in the morning. And clinics are definitely various kinds of clinics. So you have your new clinics where we see patients who come for the first time. And they're a completely different kind of patients to the ones that will come in for results. And then the ones that have had surgery and come for that results. Again, they're a slightly different kind of patients. So those clinics are quite hectic, especially in the new clinic, a large number of patients, volumes of cases. But in essence, we do the same things for all of them, and majority. They all get a good clinical examination by a clinician trained in breast surgery, or certainly in breast diseases. They'll then get their imaging if required, and imaging usually involve mammograms and ultrasound scan, depending on their age. Sometimes they don't need any of those. If they're a very straightforward history, then that's fine. Then in the afternoon, you may have say, theatre list. If it's a theatre case, we have to consent patients, so see them beforehand, talk to them about the surgery again. And these are patients who have been seen in the past, spoken about. And so they've gone through a whole series of consent and gone through a whole series of knowing what's going on. But that's the final consenting period. And then we do the surgery itself. And the surgery itself will be in theatres, specifically designed so we can have all the right instruments. We have the right number of staff there. So we have highly trained nursing staff, ODPs, anaesthetist. And we're very fortunate we get the same anaesthetist in majority of occasions. And you can tell how much of a difference it makes when we have a different anaesthetist. And then things become a bit more slower, a little bit more difficult. Not impossible, but a bit more difficult. And that would be a typical day, but obviously other days are slightly different in the sense that twice a week we'll have something called an MDT. And I teach students that the MDT is the business of cancer treatment, and is the most formative way of doing cancer treatment in the UK, and certainly no one should be practicing any kind of cancer surgery or treatment without practicing MDT. But I'm also a general surgeon, so I participate in the on-call rota. And so in those days where I'm on call, I would do slightly different things, and I would look after a slightly different group of patients. And the next day I would look after those patients as the on-call surgeon as well. So my day is slightly different depending on which day, but that's a typical day as a breast and general surgeon.
And what would you say the balance is between doing breast surgery and general surgery?
It's about 80% breast surgery and 20% general surgery. Most of my stresses are actually general surgery, for 80% of that. But and certainly nationwide, most breast surgeons are coming off the on-call rota. And in our hospital, when I first started 6 years ago, we had 3 breast surgeons on the on-call rota. Now we have 1, myself, and I'm coming off in the next couple of months. So we are basically going through what the other hospitals in the country are going through as well.
You've obviously been through scenarios where there was pre-MDTs and now MDTs are common practice.
Yes.
What do you see as being the main benefits that have resulted from the MDTs?
The MDTs to me is a cohesive way of doing your cancer treatment, and breast is, I would say, at the pinnacle of that, and we've been doing it for longer than most others. And you're right, I've actually seen MDT cancer treatment done where MDTs were not available. And looking back now, I'm shocked we even thought that was a good way of doing it. There were occasions when individuals made decisions and then they may talk to their colleagues later on. The colleagues will, no, actually, I would do it in a different way. And from a patient point of view, it's actually quite disturbing to have 2 different people say 2 different things to them. That's been taken away. What the MDT does is 2 real big things. One is it allows to refocus on the results we're going to give the patient. So the pathologist looks at the results again. The radiologist review the images again. And you'd be surprised how many times when they go back to look at those results, they will say, actually, we've seen more than we expected, or it is different to what we expected. And same goes with the pathologist. And in that context, having an oncologist assessment on that, as well as a pathologist and radiologist, the surgeons can actually give their view of what's going on. So when we talk to the patient, it's absolutely important the patient understands it isn't an individual discussion. It isn't one of us saying to them, this is the result. But this is actually a conclusion of several different experts in that field before we even talk to the patient. I think it gives them a lot of security, knowing the right things have been done, and gives us as clinicians security. Because one of the things we've learned as consultants is that we don't know everything. We can be mistaken. And so having a group discussion, liaison with your colleagues who are experts in their own field, is a huge benefit to us as well. Sometimes we live for challenges because we want to improve those situations. So having challenges is not a bad thing. But challenges that I can see are multivariate. You know, there are some things that's inherent in the job I do. Some things are made inherent by external factors, and some things, I'm afraid, the structure of where we are causing it. And if I can try and give you examples of some. As a cancer surgeon, we're dealing with extremely challenging situations, giving bad results to patients. And those bad results are at various points. The moment of diagnosis, the surgical treatment, the results of that, and the progression of the disease. Although we do less of the progression of the disease, and oncologists are much more involved in that, we still occasionally do it. And giving bad results or unfavorable results are never good for anyone. And it's a challenging situation for yourself and for your patients, and more so for their loved ones as well. Because many times you can see the patient thinking to themselves, I can fight this, and it's the loved ones that feel where we're going to go. And I keep telling my trainees and my students that unless you're in that position, I don't think we'll ever truly understand what's in their mind. You know, one moment, a perfect example I'm thinking of this moment is a young lady, very young, less than 30. And you suddenly think she had a wonderful life before, and now she can't even think about her next birthday. So it's not that she won't have it, we're expecting her to do very well, but every year must be an extra bonus years. And that's challenging for the patient, and it's challenging for us. And then we have other issues which makes a job more challenging than it should be. And that is having targets. I don't think targets is a bad thing, and I'm certainly in favour of targets, but sometimes there's targets that are extremely stringent, overtly stringent, that makes a good functioning unit difficult. And again, I'll give you an example. I agree with the early review of patients, I agree with their early surgery dates and so on. But then you have other things like if a patient doesn't attend for clinic, then they're still within target. In other words, we still have to provide them the next clinical appointment within the 2 weeks that we were offered earlier on. So you're constantly saying, well, actually, if the patient decides not to turn up, why then do we have to find slots to do them that will then take other people's slots and need them more? Those are things that's very difficult to understand. The targets are very difficult, too stringent, although I do agree with them. I think they have been a great asset to the NHS. It's allowed us to do things, focuses us on what's important, but unfortunately it's too stringent to be too useful. When it comes to rewards, I think it's almost always clinical. You know, I think when we get told we've met our targets, I feel okay. But when I see a patient, I say to them, the cancer, in my opinion, is gone. You've got a good cosmetic result. Your reconstruction is working well. That, and the patient is happy or smiling, that's the best reward. And it's something that as a trainee I never understood. When I was a trainee as a surgeon, I wanted to operate. I wanted to learn the technical skills of operating. And then when you become a consultant, you realize, my God, these are my patients, and I operate on them is just a tool for me to get them better. Whether I operate or I give them a tablet is irrelevant. Making them feel that they've got a chance is the most wonderful experience. I will never forget a lady who had one of the nastiest cancers you can have. She had an inflammatory cancer, very poor prognosis, but we gave her chemotherapy, we took the cancer out, and she had what we call a PCR, complete pathological response. Is one of the best indicators of prognosis, i.e. we expect her to do extremely well. And the happiness that she and her husband had that moment was unbelievable. You know, no amount of, meeting targets can match that. And so I agree with you. And in the sense that I think rewards are almost always clinical. Seeing a patient happy, seeing their loved ones happy. Sometimes when you give bad results and you do it in a well way, you see their satisfaction. That, thank you very much, you've done as much as you can. And you feel you're part of that. So the rewards are almost always clinical.
What are those key targets, those key measures that that you're, continually kind of monitored on, and how does that work in practice?
Okay, so there are several key monitors that we as consultants or the breast service has to fulfill. One of them is 2 weeks from a patient being referred from the GP. The patient has to be seen. In December 2009, breast services was separate from other services where it wasn't about suspicion of cancer anymore. It was about a referral, full stop. So other specialties, the GPs will establish that I'm suspicious of cancer, and so they will have to see that group of patients in 2 weeks. And in December 2009, the government said no more of that for breast services, and every single breast patient, irrespective of the suspicion of cancer, has to be seen within 2 weeks. And the government used sound data that showed that 50% of all cancers were actually in the not suspected area. And so they had a good reason to say that yes, the GP may not be fully suspicious of this, but we still have to see them. So I agree with that. And I think that's not a bad thing. The other targets we have to meet is once we've made a decision to treat, we have to start the treatment within 31 days. So that's a target. And we also know that irrespective of when we start the treatment, all of that, from the first moment of referral to the treatment, must be within 62 days. So whatever you do, you must fulfill the last target. And that target is, I suspect, the most important one. So sometimes, as I said, the complexity of the cases necessitates us to get a CT scans, get bone scans, MRI scans, a second review, a repeat CT, and so on. And so we may not always get the 31 days, but we should still meet the 62 days itself. And that's reasonable, and I have no complaints about that itself.
If you want to bring new equipment into the operating theatre environment, what's the process for that? Who do you have to persuade? How does that process work within the trust?
An example I can give you is that I've had a wonderful mesh that the rep came along and said, look, I've got this great mesh. I'll say, fine, I can see some of the advantages, but I now need to see the evidence. They've shown me the evidence. Then I say, fine, I need to see how it's worked. So I went to Germany. I went to some of the surgeons working in Germany to see how they work. Once I'm convinced it works, I've seen how they've done it. It's no different to, or much different to what I'm doing at the moment. I would then talk to my service lead, and then if we both agree that this is a good thing for the department, we will then have a chat. If it's not already on the business plan, in the sense if it's just a mesh, a slightly different mesh, that may not need a business plan. But if it's something completely new, I will then, with the company, usually set up a business plan to see that this is an efficient way of using the hospital resources. By efficient, I don't mean it's cost effective, it's cheaper, I just mean that this is the best thing for that amount of money for that kind of patient. So it's not about the cheapest, it's about a much more efficient way of doing it. And then obviously if it's accepted in the business plan, then we would make sure that that's then readily used. There's training for myself, training for my colleagues, and then we would utilize that on a regular basis itself. And then we would collect data. So if we use something new, normally audit up our thing. We will normally say, so 3 months, collect that data, and then present it to ourselves. We've used something new, it's wonderful, these are the results. But one of the things we find that no matter how wonderful they have problems, and so we all need to know what those problems are. You find a way of working around that problem. Sometimes it's by saying, well, actually it's not as good as we thought, or by saying, let's wash this a lot more than the manufacturers say, or let's use it in a slightly different way. So new technology is absolutely crucial to the NHS.
So let's just come back to the final question, the magic wand question. If you could wave a magic wand to change one or a couple of things, what would that be?
Yeah. I think if you take it nationally, I would like a much more sensible approach to targets. And I think that will help everyone. And that includes the patients. Because I think one of the things we try and tell patients is, and us giving them surgery so quickly is not a sign of their cancer being so bad, it has to be done. So patients come in expecting that if they don't get operated within 2 weeks, the cancer is going to spread everywhere. And we've made it quite clear to them, actually, the evidence for that. And evidence-based medicine tells us it takes significantly longer than that, many months before cancer upstages. So we do have time on our hands.